All right. We've got a few studies on the docket tonight. This is actually going to be a quicker night because a lot of them overlap in what they're saying. They're just there to add weight, basically because they're saying the same thing. So the first one is short-term effectiveness of tibial nerve flossing in patients with tarsal tunnel syndrome. So think carpal tunnel, but for the feet. And what we have is we have what's called nerve flossing. So we're getting this nerve to move because whether it was through the pain process, the actual pathology, whatever it was, one of two things is happening. Either the actual nerve is kind of bogged down because there's local inflammation around there, so it's kind of getting squished and can't move as well, or there's pain associated with the movement and it's, there's nothing like physically wrong, but we have the condition, so we know there's something wrong. Basically, both of those scenarios are great for when it comes to tibial or to nerve flossing in general, is if the nerve is actually bogged down because of a natural inflammatory process associated with the condition, or because there's pain with the movement from a brain-based mechanism. Basically, you don't want to go, it's like the Frankenstein. You don't want to go near your fire because you know it's going to hurt you. Some people are afraid of certain movements because they know there's going to be pain. This is also a great way to introduce movement for those people. But basically, you take this nerve and you get it to start gliding along and moving better. And what they found was, so long as they had both groups doing the exact same thing as far as conventional treatment, adding in this nerve flossing to tarsal tunnel syndrome really had significant improvement in all tested variables. So something to keep in mind as far as when we look at similar conditions, there's really not a good reason to not add a nerve floss in if we're going to have such a great benefit, especially for tarsal tunnel syndrome. But moving on, because there's a few studies here, rotator cuff trigger point dry needling versus sham in a randomized control study. Basically, in a few patients, I wish there were more, in a pretty wide age demographic, they found that compared to sham, so actually I'm just going to go to results versus conclusion first, dry needling significantly improved shoulder stability, which kind of surprised me. Grip strength, which didn't, and pain, mainly for that reason. I usually think that grip strength is also associated with pain, so if you improve that, you can improve grip strength, but the shoulder stability one surprised me compared to sham dry needling. All improvements exceeded minimal clinically important differences, and at 1 week follow-up, the outcome still favored dry needling, which I found really cool. Basically, this is one of those things where when I discuss treatment options for patients, this is one that I may have to keep in mind. So insofar as if more studies come out like this, I may have to discuss with my patients like, hey, all of these are fair in love and war, but we do have studies that for like shoulder, dry needling works really well. For neck, there's some studies as far as like lower or upper thoracic and lower cervical manipulation combined with instrument work has fantastic outcomes. So does dry needling, especially when it comes to range of motion and disability. These are all things that I now get to discuss with patients as far as what is the best option for them at the time, given their goals, what is wrong, their condition, etc. And this is one that I'm going to have to keep in my docket as far as shoulder pain goes. We're having a few more papers come out that demonstrate some pretty cool effects with dry needling. Now, shoulder morphological changes in glenohumeral maximal external rotation. Basically, this was something that this study kind of goes over what was already discussed in some of my education when I was going through school. And that is there are morphological changes or anatomical changes associated, at least in this study, sport. What do I mean? So they included 15 male university adult baseball players from a competitive team, and they measured posterior glenohumeral distance, a relative approximate area of impingement via an MRI. And what they found was using an analysis based upon their measurements, they were able to associate that there was a morphological change happening in the shoulder. So we go to the conclusion, glenohumeral angle was associated with posterior glenohumeral joint and approximate percentage of area of impingement, which reflects morphological shoulder changes. And they go on to say, assessment of excessive external rotation of the glenohumeral joint during the late cocking phase contributes to the understanding of morphological changes in the shoulder joint and related throwing injuries. That related shoulder injuries one is kind of what they're really hinting at. They're basically saying excessive external, what is that? If we go by normal variance guidelines, the shoulder should have a total of 180 degrees of joint range of motion for a healthy working shoulder, because this thing has to do a lot. The joint has to be able to move so that I can do all these tasks with my hands, etc. And typically you'll see books that talk about, it should be like, if the range is like 160 to 180 degrees, it should be like external versus internal. You have like a relatively even split. Maybe it's like a 180 or 110 and 70. Well, in baseball players or anybody that basically needs to really get this arm back to propel an object forward, that mechanism is going to basically coax the shoulder, especially when we're going through adolescence and our growth years, to adapt and adopt changes that allow for more range of motion here, more external, and it's going to then shore up or buttress or reinforce a lot of this internal, so it's going to stop it sooner. So in baseball players, you may see like 130 degrees external, 50 degrees internal, but they still get that 180 degrees. What they're saying is yes, there's now morphological changes measured in these 15 male university players, and that these changes could be related to throwing injuries. And I'm not going to disagree per se, but there's a lot that goes into injury. So much so that I'm not going to just lay my entire hat on, okay, yeah, it's the morphological thing that is causing this player issue. I think clinically, it really, if anything, it narrows your goal on what to do with that person at that time. And what do I mean? Well, if you go to any practitioner that doesn't understand that these morphological changes happen, and they measure like, oh my gosh, there's 130 degrees external and 50 degrees internal, we have to reinforce the external. So we have to limit how much external your shoulder's getting, and we have to try and force all of this extra internal. Well, it's a morphological change. Good luck trying to get that within a short period of time. Also, maybe that's part and parcel of their job. Maybe it's an advantage that their body is adapted to, so you don't want to necessarily change it. If anything, it just tells us, okay, so maybe a range of motion issue isn't the goal. We have to be a bit more functional in our approach as far as what we do for these patients. So if anything else, it also may talk about, okay, so they're saying it's related to shoulder and throwing injuries. Again, not necessarily going to disagree, but maybe it's also one of those where you have to start going into a bit of a gray area to adequately treat these patients, because they're going to have that natural morphological change and they're not going to be textbook quote normal. So things like, oh, their scapulohumeral rhythm is off. Well, of course it's going to be the conventional measures. They're like really recruiting this, so they're going to really dip down this way. Basically, what I'm trying to say is this was already discussed in school. This, I can't believe how many years ago this actually is now. I'm still of the opinion that as long as they have total range of motion to accommodate the tasks at hand, I am not necessarily concerned about excess unless we have other pathologies such as dislocations, etc. It also will kind of reinforce that a lot of the injury mechanisms may have a mechanistic aspect to them. There may be certain things like, okay, there may be certain tendinopathies that develop sooner because of that morphological change that I may have to keep in mind. But it also means that I'm going to have to be much more open in discussing with this patient more functional outcome goals, because they're not anatomically, quote, population normal. So, oh, I can take my, I'm not going to pull it out, it's buried. My dynamometer, or not my dynamometer, my goniometer and inclinometers, we're going to measure range of motion, we're going to improve it this way. No, that's not my goal anymore. My goal is, what does this athlete need to do? What else is going on in their life that we need to address and accommodate for? And are there certain things they're more predisposed to? Maybe. Are there things they're less predisposed to? Also maybe. And we have to have that conversation at that time and be willing to work in a relatively gray area to give them the best care possible at the time. Now, gray doesn't mean without principles, without backing. It just means we have an honest conversation. But I'm going to get rambly, I'm pretty preachy, and I want to keep this relatively short. And I'm going to have to update my settings back to allow for longer videos because it keeps wanting to kick me out here sooner versus later. All right, next up, morphological characteristics of the thoracolumbar fascia. Here's where we kind of have a lot of the studies saying similar things. Its relationship to chronic low back pain and back extension strength. So as far as pain goes, like all the other studies, boom, no significant differences in morphological characteristics between participants with and without low back pain, chronic low back pain. So the actual shape and structure or appearance, whether yours is slightly broader or thicker, doesn't really play a role in if your body perceives it to have pain. About the only difference that I think this study showed was here. In chronic low back pain participants, there was, let me go back a couple of sentences here. The thoracolumbar fascia circumference and fat surface contact, so surface level fat, in chronic low back pain patient participants were significantly correlated with back extension strength, contrary to healthy controls. So we have more of a functional reason where the musculature or what they measured may fatigue out sooner, and the body will then try and put forth a pain mechanism. And again, this is theory right now, to tell the body like, hey, we need to back off. We don't have the capacity to keep doing what you're asking of it. So the actual structure doesn't seem to correlate. But the circumference and fat surface contact correlated with back extension strength. And in my opinion, that is more likely than the actual structure of the tissue itself to contribute to people having pain versus the actual structure. I'm going to get very repetitive here. So future studies investigating the characteristics at multiple spinal levels while considering multidirectional, multi-layered implications of that fascia are needed to clarify the role of its morphology in spine biomechanics. Basically, they don't know what it do, how it do, and what we need to think about it in how complex the human condition is yet, if we're ever going to get there within the next couple of decades. Now, this one I just wanted to bring up because it's a up-and-coming biomarker. So we all know of BMI, but what might be slightly more accurate, but slightly more cumbersome, but not quite so as actually getting people to go through a bunch of scans and really analyze it, or doing, I believe it is like water volume displacement test, etc. The body roundness index. So like they kind of say here, is a novel metric that is currently being researched and having pretty good accuracy. And they just wanted to take, all right, is there any association between osteoarthritis? Well, they found that, yeah, there is an association, and that association remained unaffected by variables such as race, age, gender, etc. And basically, an increased body roundness index is associated with a higher prevalence of osteoarthritis, particularly in obese populations. And they say that this is an additional reason that body roundness index is expected to become a valuable indicator of identifying individuals at high risk for things like osteoarthritis. So why might this be? Is it because of the excess body weight? No, if we go back to other studies, a lot of what happens is in these conditions that have metabolic components or metabolic disorders, dysfunctions, etc., where we have things such as obesity, the process of obesity itself on your body, diabetes, etc. All of these may not be causative of one another, but the population that has one, they overlap quite a bit. And what happens here is when we have this body roundness index, as it goes up, you're going to see a lot more higher incidence of these people that have these conditions. It's not purely the excess weight that is leading to the osteoarthritis. It is the chemical state, the environment that the body, the joint, and the bones are in that are prone to leading it to developing osteoarthritis, at least as far as what I've seen and studied. So anybody, like, if they want to fight me on that, we can take a look at people who are like power lifters or weightlifters, and we can look at other populations that deal with excess weight on their body. And a lot of the times we actually find that it is joint protective. Another thing we can take a look at is runners, moderate body weight, light body weight, comparatively, it's basically low body roundness index. And we actually find that no, running actually doesn't increase the prevalence of things like joint degeneration and knee osteoarthritis, which you think it would. And the fact that running puts such larger impact forces through these joints, you would essentially have the same mechanistic reason to think that excess body weight leads to joint degeneration, just like running would lead to joint degeneration, and that's not what we find. What we find, at least as far as this group goes, it is likely the chemical environment, the inflammatory states, etc., that leads to the osteoarthritic condition versus the actual mechanical load on the joint itself. And then we have, again, a couple of those studies that are saying what I talked about at the beginning, imaging findings in patients with clinically diagnosed, always when I'm talking, clinically diagnosed gluteal tendinopathy, a secondary analysis and of a randomized controlled trial. Basically, I'm going to jump to the conclusion for these because I've been saying this for quite a long time, and I've got an imaging study that says essentially the same thing. In a clinical trial of people with gluteal tendinopathy, a substantial number of participants had multiple tendons affected, as well as other tendon tears and calcifications, and MRI detected changes were not associated with levels of pain, function, or disability. You are not your MRI. If there's reason to think you need an imaging study, we will discuss the reasons why, and we will also tell people that there's a fair chance that we're going to find something on there. It is up to us to figure out if it's actually related to what we're looking for, or if it was just a happenstance finding. Basically, just because it is there doesn't mean it's an issue. Okay, and this one kind of says the same thing. Thoracic degenerative MRI findings in association with pain, disability, systematic review. And we'll go right here to, does the conclusion say it outright? Okay. No definitive conclusions could be drawn about the prevalence of thoracic degenerative MRI findings or their association with pain and disability. Yet again, let's go to a handout that I like to kind of give patients here. What do we have? Half of the people above the age of 60 have asymptomatic rotator cuff tears, and this was, I think this was even as of like 5 to 10 years ago when we were finding these things out. 85% of adults have knee arthritis that they didn't know about and don't have pain that they're complaining about prior to the imaging study. A third of all people have heel spurs with no pain. There is lumbar disc degeneration present in 40% of individuals under the age of 30 and 90% of those above the age of 50. And in healthy 20 to 22-year-olds with no back pain, basically half had a degenerative disc and 25 had a bulging disc. I'm in that category. You are not your image. Okay. So I've had people come into me and it's just like, oh my gosh, I have such a bad blah, 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 blah. It's like, do you have symptoms? Some. Okay. So your symptom severity is not matching the MRI study severity. That's what you're telling me. And that's not surprising to me, but it's often very surprising to people when we talk about it. Or they get an x-ray and they're like, oh my gosh, my spine is so bad. It's like, not really. You were, functionally capable right over there. Like you didn't know until you knew. And now you knowing is the problem. We got to work around that. So I am not a fan of just blanket imaging studies for cause reasons. Just, oh, well, we should consider it like another biomarker. You should get your spine checked. You should get your joint checked. Not without reason. Not without reason, because from a population standpoint, we can have just as much problems caused by having people find out what's on an imaging study as we can catch things that would actually help people. There has to be a clinical reason to get that imaging study. Okay. Now, there are other diagnostic tools that I'm much more open to just having patients go get on their own just cuz. Lab work is one of them. Okay. Blood pressure, another. In fact, I should probably check my blood pressure here just so that we have an understanding of where it's at. And let me stop sharing here. Stop presenting. Here we go. We need to stop trying to go to this top fancy end and get all these cherry on top studies. MRIs just because we can, X-ray imaging just because we can. We really need to go back to basics for the things that impact us the most as far as our overall health goes. And a lot of those are either fairly inexpensive or a lot of things that we can do. There are physical metrics that correlate to overall health, and those are cardiovascular and strength-based, which means you can stress test yourself. Like How fast can you run a mile, or how many sit to stands can you do in a minute? How many push-ups can you do in a minute? What's your relative grip strength? All these things are low-hanging fruit that correlate very, very well with your health in the long run. We should be measuring our blood pressure periodically throughout the year. In fact, I've neglected to do mine the last quarter, and I should probably break out my cuff, make sure it's good, and measure my blood pressure consistently at the same time every day, couple of readings for about 2 weeks to collect an average, and do that quarterly. So I actually have an understanding of what is my average blood pressure. Do I need to be concerned about it or not? Same thing with lab work. If you go to your doctor once a year to draw labs and there's only a few labs there, well, if things are starting to build up in that year, you're going to have to wait till your next lab work to figure that out. So a basic set of labs can help us understand your health state and just track it for relatively inexpensive amounts of money. We don't need highfalutin MRI studies. We don't need extreme specialty things to tell us how well we are doing. A lot of these are in our control. A lot of these are simplistic. A lot of these are inexpensive. These are the things that we need to be concerned about. Let's go back to basics, because those are going to be what actually will dictate our health in the long run. I'm going to stop rambling there, and until next week.